glomerular diseases in childhood. I think Dr. Erang has done what you've seen as adults, right? And when it comes to the pediatric aspects, there are only few conditions that you should be aware of or you should know about. Not like adults, we don't have many diseases, very few common diseases, right? Right. During this hour also, I'm going to discuss mainly on nephrotic syndrome and post-streptococcal acute glomerular nephritis. Those are the two common conditions that mainly we see in pediatric practice. There are other conditions too, but for your purposes or module purposes, I don't think that we need to go into details regarding the rare cases we see in pediatric practice. But nephrotic syndrome and post-streptococcal acute glomerular nephritis are very, very common conditions you see. Right, in nephrotic syndrome, I will go through briefly regarding the initial presentation and the treatment, and how we manage children with frequent relapse in nephrotic syndrome and steroid-dependent nephrotic syndrome, and how we are going to decide on second-line medications and the briefing on place of albumin and place of diuretics. Post-streptococcal acute glomerular nephritis, we will look into their presentation and how we are going to manage. Now, when you took these two conditions at the onset, I would like you to understand the difference, right? If you take nephrotic syndrome, if you look at its pathophysiology, you see that there will be you lose protein in the urine, therefore low protein in the serum, and then the oncotic pressure inside the vascular system will come down. Therefore, there is a tendency for hypovolemia. For nephrotic syndrome, you should understand that it is always there is a tendency for hypovolemia. Now, if you take a nephrotic syndrome or a post-streptococcal acute glomerular nephritis, the pathophysiology is totally different. Due to the glomerular damage in the post-streptococcal acute glomerular nephritis, there is a reduction in the GFR and there is a fluid retention. Therefore, there is an intravascular volume overload, which end up with causing hypertension. Therefore, nephrotic syndrome or post-streptococcal acute glomerular nephritis, which present as a nephrotic syndrome, you are in a state of hypervolemia. Nephrotic syndrome is a state of hypovolemia. Nephrotic syndrome is a state of hypervolemia. That's concept you should understand very well. With that background, I'm going to discuss nephrotic syndrome. And most of these statements depend on the evidence and the quality of the evidence. Now, if you look at the idiopathic nephrotic syndrome in childhood, if you look at the idiopathic nephrotic syndrome in childhood, it is a commonest chronic glomerular disease of childhood, right? It is a commonest. And incidence is 2 to 4 cases per 100,000 in the world. But you have to remember that if you look at the South Asian countries or Asian origin, the incidence is higher, right? Therefore, in Asian countries, we see more children with nephrotic syndrome compared to the Caucasians. Now, there are some classification when it comes to the nephrotic syndrome, right? And there is 3 classification. The first classification is the etiological classification of nephrotic syndrome. Etiological, where you divide nephrotic syndrome into primary nephrotic syndrome and secondary nephrotic syndrome. Primary, you have subcategories like congenital nephrotic syndrome and idiopathic nephrotic syndrome. Or there is another in-between category, what you call infantile nephrotic syndrome. Therefore, idiopathic nephrotic syndrome is coming under primary nephrotic syndrome, and the secondary is usually due to other causes. For example, if they develop nephrotic syndrome following vasculitic diseases like SLE, HSP, those children are coming under secondary nephrotic syndrome. Sometimes they can develop nephrotic syndrome following drugs, for example, gold, penicillamine, heavy metals. Those can cause nephrotic syndrome, and it is coming under the category secondary nephrotic syndrome. That what you call is the etiological classification of nephrotic syndrome, primary and secondary. Then you have the categorization, what you call histopathological classification. Where you can divide nephrotic syndrome into minimal change glomerulonephritis and non-minimal change glomerulonephritis. Right? That's a histopathologically. You have the minimal change and non-minimal change. If you look at the biopsy of nephrotic syndrome, 80% of them are having minimal change disease. Another 20% or so are having non-minimal change. Non-minimal change you can see can subcategorize into focal segmental glomerulosclerosis, mesangial proliferative glomerulonephritis. The subcategories can be there under non-minimal change. This is a histopathological classification of nephrotic syndrome. And there's another classification that is called clinical classification of nephrotic syndrome, depend on the steroid sensitivity. There you divide nephrotic syndrome into steroid sensitive nephrotic syndrome and steroid resistant nephrotic syndrome. Right? And steroid sensitive, you can further subcategorize into frequent relapsing, infrequent relapsing, frequent relapsing, and steroid dependent. Steroid sensitive nephrotic syndrome. Then you have the other part is the steroid resistant. Therefore, nephrotic syndrome, as I now briefly mentioned, can subcategorize or classified in different way. And as I mentioned, there can be etiological classification, then you can have histopathological classification, and then you have clinical classification depending on the steroid sensitivity. More than 90% of patients respond to corticosteroids or oral corticosteroids. Relapsing is a common nature in this disease. About 80% of children relapse, and 50% of children develop frequent relapsing or steroid-dependent nephrotic syndrome. Means that there will be a category of about 50% of children who may need second-line medication to counteract the steroid toxicity. Now, this is the clinical classification I have mentioned, steroid-sensitive nephrotic syndrome and steroid-resistant nephrotic syndrome. You should have some idea regarding these definitions. For example, infrequent relapsing nephrotic syndrome means that if you have less than 4 episodes for a year, it's a frequent. Less than 4 relapses for a year is a infrequent relapsing. If you have 2 relapses within 6 months or 4 or more within any 12 months is a frequent relapse. Then you have the steroid dependent. The definition is as such that 2 consecutive relapses as the steroid dose is being tapered or within 2 weeks of stopping. Then the other main part is a steroid-resistant nephrotic syndrome where you started treating with the prednisolone, the induction dose, but if they are not responding after about 4 to 6 weeks, you label them as a steroid-resistant nephrotic syndrome. When it comes to the nephrotic syndrome, there are atypical presentations. Usual age group is 2 to 6 years. This is the usual age at the present. But there are atypical features. Atypical features, what they suggest, atypical suggests that the child may be having non-minimal change disease. That's why the atypical features are suggestive of. And these atypical features also you can use as indications to do a renal biopsy also. Therefore, atypical features are very important. They suggest that child may be having non-minimal change. And also, you can use same features as or indications as the renal biopsy. Right? What are the atypical features? Age less than 1 year or more than 9 years, macroscopic hematuria, and significantly and persistently raised blood pressure, deranged renal functions, extrarenal manifestations like vasculitic rashes, and the family history of nephrotic syndrome. If you have those features, you can use those features as indication for the renal biopsy, and they suggest that those features suggest the child can be having non-minimal change disease. What are the complications you can have with nephrotic syndrome? At very beginning, I mentioned hypovolemia is a feature of nephrotic syndrome due to reduced oncotic pressure. Therefore, you always have to evaluate the child for features of hypovolemia. Abdominal pain. Nephrotic syndrome children can develop abdominal pain due to many reasons. If you take few causes for abdominal pain in nephrotic child, you always have to exclude hypovolemia. Hypovolemia can cause ischemia to gut, and abdominal pain would be the result. And sometimes they can develop peritonitis because they can have free fluid in the abdomen and can end up with peritonitis causing abdominal pain, deep vein thrombosis, pancreatitis, maybe even gastritis following the therapy also can cause abdominal pain in this group of children. Infections, as I mentioned earlier, peritonitis must be considered if there is abdominal pain. This is very, very important. And other infections also, maybe they may be in a higher risk category. As we know, they are on immunosuppression. At the same time, they are losing immunoglobulin in urine. Therefore, they are in a state of immunodeficiency. Therefore, you should have a lower threshold of identifying or treating infections in children with nephrotic syndrome. Thrombosis is another complication. It is mainly due to the hypercoagulability associated with hypovolemia, and they can end up with thrombotic complications. Edema is a feature of disease sometimes, but they can have a significant edema or distressing edema. Then you can take it as a complication. And it can end up with colon fluid effusion, pericardial effusion, and scrotal or genital edema, and causing discomfort to the child. Right. Now, after you diagnose nephrotic syndrome, treatment is very much straightforward. We know, as I mentioned earlier, is very, very steroid sensitive. Therefore, prednisolone is the drug of choice. Therefore, we usually start with 60 milligram per square meter. Daily prednisolone dose usually given in the morning until in first episode we continue it for 28 days. Then we gradually tail it over 4 months. Now there is early the most what to call the oldest one is ISKDC regime, and then KDIGO guidelines as propose another regime. We in our country most mostly we use this therapy, this protocol. This is a modified version of KPI guides that surely carry it off over 3 months duration. There are some evidence that longer induction courses are associated with longer time to the first relapse. But recent studies have shown that after 2 years of after the initial episode, the duration you have treated in the at first was not going to alter the relapse rate. Managing a child with frequent relapse in nephrotic syndrome or steroid-dependent nephrotic syndrome. As I mentioned earlier, now there is a high chance of they develop 50% of them they develop frequent relapse in a steroid-dependent nephrotic syndrome. In other words, they need second-line medicines to reduce the steroid side effects. There are a few drugs that we use, levamisole, cyclophosphamide, cyclosporine, or tacrolimus, and rituximab. Those drugs can be used as steroid-sparing medications. When they need steroid too frequently, we need to switch to a steroid-sparing medication in the view of reducing the side effects. Now, this is a simple chart. You don't need to buy hard this. And this is just for you to understand how we decide on second-line medications. Now, frequent relapse in nephrotic syndrome, this first, initially we usually start with levamisole, and then according to this chart, we go around cyclophosphamide, oral cyclophosphamide, and MMF. You can be try with. Steroid-dependent nephrotic syndrome, cyclophosphamide is a better drug if it's tolerating to start, and then you can think of your mycophenolate, mofetil, and even cyclosporine at the last. Steroid-resistant nephrotic syndrome, cyclosporine is very important drug, and then finally you can see you can go for a combination of therapies if they are still, if the child is relapsing and not showing any response to your treatment. And then later, now we now have what you call CD20 monoclonal antibodies. You call it as a rituximab. And it has changed the behavior of the disease so much that we now use in severe dependency, we usually use rituximab to cut down other medications. You know, these children, as I mentioned in the introduction, that they are losing protein and they are in a hypoalbuminemic status. Remember that degree of hypoalbuminemia does not correlate with the degree of hypovolemia always. Therefore, in some children, they need albumin, especially when they are hypovolemic or if their urine output is less than 0.5 ml per kilogram per hour. Because if we keep this hypovolemia to continue, these children can end up with having acute tubular necrosis or ATN due to hypovolemia. Therefore, we usually intervene if the albumin is low, and especially if the urine output is coming down, and especially if it's less than 0.5 ml per kilogram per hour. And we can give 20% human albumin, that's what's available in the world. 20% means it's almost 4 times concentrated than the blood albumin level. Therefore, you need to give it slowly. It's about over 4 to 6 hours. You can give it very slowly, and then with the midday furosemide. And usually we don't repeat albumin more than once a day. Therefore, in some instances, we need to use albumin. And when you use albumin, you need to be careful that you should, aware that you should give it slowly. What is the place of diuretics? I think in adult practice, there is what to call the frequently used diuretics, but in pediatrics we don't use frequently. If the edema is severe, diuretic can be used cautiously if the vascular volume assessed clinically to be normal. For always you have to assess the hemodynamic status and the intravascular volume before you prescribe diuretics. When you prescribe diuretics, you have to give good enough dose because when there is a low albumin, response to furosemide is blunted. And therefore, we usually give 1 milligram per kilogram per dose. Another important factor is that sometimes, due to aldosterone overactivity, these children can have fluid retention or they retain the fluid. Therefore, sometimes we need to use spironolactone or amyloid to antagonize the aldosterone action, and then it will can reduce the what you call the edema of the child. Another important question a lot of people keep on asking regarding these vaccinations and the steroids and immunosuppression. AAP guidelines, American Academy of Pediatrics, the recently published guideline, they mention that even when the child is on low dose, small dose, every other day prednisone, they can be given live vaccines. But in our country still, in our country, we usually wait at least for 1 month after stopping the immunosuppressions before you give live vaccines. But as I mentioned, AAP guidelines, American Academy of Pediatrics, mention that while they are on very low dose of every other day steroids, you can give them with live vaccines. If you have taken the prednisolone higher dose, you need to wait at least 1 month. And MMF cyclophosphamide, CNI calcium inhibitors, you need to have at least 3 months. Rituximab and amiglobulin recommendation is to wait for 6 months before you give your live vaccines. If you have, I think you may start visiting wards during next few years, and you will see children who have been labeled as children having transient proteinuria. Transient proteinuria is where you can develop proteinuria, especially associated with the infection, and it can end up spontaneously or it can lead to a relapse. Usually they are having non-hepatic range proteinuria. There is no edema. Serum albumin is usually more than 30. Serum cholesterol is normal. You can give a small dose of prednisolone daily for about 5 days and observe if you are thinking of transient proteinuria. Otherwise, if it's not settling and if it is continuing and you have the low albumin and especially low albumin, you then need to treat it as an albumin edema. Then you need to treat it as a transient. If there is edema, especially, then it's a relapse, right? Now, if you look at the transient proteinuria, usually there is no edema. Serum albumin is more than 30. If serum albumin is low, if there is edema, then it's a relapse, not the transient proteinuria. Therefore, don't get confused with these terms. Therefore, relapse and the transient proteinuria is two different entities, right? Relapse where you need to start the prednisone with the higher recommended daily dosing. But in transient proteinuria, you can give short course of steroids, maybe for about 5 days. Okay. I went to nephrotic syndrome. Do you have any questions before I switch to AGN? Any burning questions to ask? Can ask. You can ask now, right? We can discuss about 5 minutes or 10 minutes. We can discuss any questions you are having. Anybody? Now, usually, I'm not sure why now half a group, now almost all days there is a participation is less than 100, no? And there is, I think that's not very positive about this number of participation. Now is today is about 86, and I have realized that it has been always less than 100 in your group. Hmm? But if there are no questions, we will switch into acute glomerular nephritis. Now, acute glomerular nephritis, they usually present as nephritic syndrome. Acute glomerular nephritis is the underlying pathology, but they present as nephritic syndrome. Clinical presentation is with nephritic syndrome. Therefore, they can have macroscopic or microscopic hematuria with oliguria, and the features of fluid overload such as hypertension and edema, and they can have renal dysfunction. Usually is a very mild dysfunction. If you take acute glomerular nephritis, post-streptococcal is the commonest. 80% of time it is a post-streptococcal acute glomerular nephritis. Not like nephrotic syndrome, nephritic syndrome, usually they present a little bit later in the life, usually 4 to 12 years of age. And we know is usually the type 3 hypersensitivity, where you get the immune complex deposition in the glomeruli and activate the alternate pathway. And that's how this destruction initiated and happened. And that usually follows pharyngitis or upper tract infection, infection or skin sepsis. If it's following the short throat or upper respiratory tract infection is usually 1 to 2 weeks. Following that, you develop features of HEA. But if it's a skin infection, it takes about 3 to 6 weeks. Prognosis is excellent. 90% of them become fully recovered. I said that they can present as nephritic syndrome. Therefore, there are other conditions also which can present as nephritic syndrome. IgA nephropathy, henoch-Schönlein purpura, systemic lupus erythematosus, ANCA-positive vasculitis, Alport syndrome, and membranoproliferative glomerular. They all can present as nephritic syndrome. That's why our clinical history, examination, and basic investigations are vital in managing these children. What aspect you look into when you do your clinical examination? What are the main aspects or main areas? You need to look at the height, weight, and the estimated body surface area. Blood pressure is mandatory. If anyone forget to measure blood pressure in a child with HEN, surely that is not acceptable. And then you assess the cardiovascular system and the features of fluid overload. As I mentioned, nephritic syndrome is the status of fluid retention and fluid overload. Therefore, you need to look at the features of fluid overload and then examination for rashes and joint involvement, where you can identify secondary causes. Or you can identify the other causes like underlying vasculitis syndromes by examination of the rashes and the joints. Investigations wise, first thing you look at the urine and see whether there's a macroscopic or microscopic hematuria. When you stand the sample or when you keep the sample on room temperature or room air for some period of time, if it's a hematuria, you can see a precipitant of red cells in the bottom of the cup. The upper part will start clearing up. You do urine flow report, urine culture, because we know if you take a hematuria can be a feature of urinary tract infections also. Therefore, you look at the urine flow report and urine culture. Urine microscopy is very important for cast and dysmorphic cell. We know red cell cast are pathognomic of glomerular. Then you can do blood tests, especially to look at the renal functions. And to confirm the diagnosis, you need to do anti-streptolysis titers like ASOT and the complement and so on. Those are very important investigations where you can confirm the diagnosis and also you can get an idea about the severity of the condition. Management of acute pulmonary hepatitis, very simple but very specific. They usually resolve spontaneously and treatment is supportive. 95% of patients with post-streptococcal pulmonary hepatitis will make a complete recovery. That's very important. Small proportion will develop rapidly progressive pulmonary hepatitis, what you call RPGA, very small proportion, then they need immunosuppressions. Other component in the management is fluid balance, hypertension, and follow-up. How you do your fluid balance? Input-output is very important. All children should be weighed daily. All patients should be on low salt diet because increased salt, increased fluid retention and cause increased blood pressure. The child is oliguric. We need to restrict fluid input to replacement of insensible losses plus previous urine output. If overload, we need to give oral furosemide or IV furosemide to induce the negative fluid balance. And we'll try to keep the child euvolemic, right? And if the child is oliguric, we need to make sure that we are not overloading the child. And if they're already overloaded child, furosemide will be useful in managing them or controlling their blood pressures. Right. I think I went through, because it's usually the medical people has already done a bigger part. I mainly look into the pediatric aspects, the two common scenarios you see in the ward, nephrotic syndrome and acute glomerulonephritis. There are a lot of other things you learn about these two conditions when you come to the clinicals. And I can answer if you have any questions. We have enough time, right? Therefore, if you have any questions, feel free to ask now. We have about 10 minutes to discuss any questions if you have. Do you have any questions? Okay, if you don't have any questions, I think we can stop now, right? And anyway, I will upload this presentation to the LMS, right? Okay, thank you.